Our topic now is transplantation, which of course is defined as the surgical act of moving tissues or organs from one location, one human being, to another. And so realize that we do transplantation in a number of different ways. And first of all, defining those is important to understanding how we will ultimately deal with the process of the potential for rejection. Since the HLA is the most polymorphic genetic system in the human being, and since each of the class alleles is carried in 2 copies on each cell, realize that I've got a total of 12 possible molecules that I need to match perfectly if I want to say that that is a perfect match that would not be recognized. So it's a very complex problem, and the fact is that without immunosuppression, virtually any transplanted tissue or organ will eventually fail. Now, transfusion is what we call it when we transplant blood, okay? And since erythrocytes have no HLA on their surface, then we don't have any worry about that type of rejection. But we did speak already about the fact that preformed allo antibodies are made against ABO glycoproteins that are unlike your own. And that happens because of the fact that we are sensitized by our normal flora to their glycolipids, and therefore we will spontaneously have IgM antibodies against those molecules. An autograft is a transplant from one location to another, so keep in mind that that has very little problem occurring. Your body doesn't care where things are. It just cares that they are yours. So this is the one example of things that we would not have to immunosuppress. An isograft is a transplant between monozygotic twins. And realize even monozygotic twins, which are said to be genetically identical, even they have minute changes that are going to happen during gestation and development. So even they are not truly identical and would need to be immunosuppressed. It's true that we probably would require less immunosuppression, but still there would be some required. An allograft, probably the most common of the techniques. This is transplantation between non-identical human beings, anything further apart than a monozygotic twin. And a xenograft, of course, the transplant between species. Now, as you can imagine, the further away you get from the human being, the more likely that there will be rejection that's quite speedy. But still, we can use pig heart valves because they are avascular tissues. And in those cases, we will not see rejection in a very rapid sense at all. So that's the one example of it being used rather commonly. Now, getting us back to the good old Nirvana diagram again, realize that the problem here is that your body has evolved to recognize invaders. Your body does not discriminate whether that invader is trying to help you out or that invader is trying to do you harm. It simply says, you are not me, I'm going to kill you. So the entire process of the immune response will begin either by the APCs of the recipient ingesting debris of the engrafted cells and then presenting those peptides in the context of MHC class II, or it may be true that the donated APCs found in the engrafted tissue can simply look different enough because of their different MHC molecules that they directly stimulate the T helper cells in order to make them respond. But either way, it's always an antigen-presenting cell presenting peptides to a T helper cell, that T helper cell then receiving the signaling that this is a peptide that is either inside or outside from the source, And in either of those cases, I would load in MHC class 2 and present to a T helper who is then going to transform based on signaling either into a T helper 1 or a T helper 2. Now, in most cases, when we're talking about cellular peptides reflecting a foreign cell, then it's going to be the pathway of the T helper 1 that is stimulated first. And so when I see what we call acute rejection, this normally takes days to weeks, just as it would take for a primary cell-mediated immune response. And I'm going to get my sensitized T helper 1 cells then signaling downstream to activate and clone the effector cells of cell-mediated immunity. And the only time we actually nowadays see acute rejection is in those cases where the patient has been non-compliant with their immunosuppressive therapy. Because although I hesitate to say that we have good immunosuppressive drugs, because I think that's an oxymoron, I certainly would say to you that we have very powerful immunosuppressive drugs. And so if a person is compliant with that regimen, we see very little of this. Chronic rejection is one we have more trouble preventing because of the fact that over time, the conspiracy of the immune response against the engrafted tissue simply causes damage and fibrosis and so forth. So I get damage to the blood vessels, I get smooth muscle proliferation, eventually occlusion of blood vessels. And so over years to decades, in the best of circumstances, I will typically have most organ transplants fail. Now, the one you really do not want to see during your medical career is the one on the right, which is a reflection of the T helper 2 side of the cascade being available at the time of the surgery. Notice that when I was speaking down the left-hand side of the diagram, I was going sequentially through the activation of T helper cells, the development of CMI, and of course, I could have some of that debris processed to produce antibodies as well. But that's sort of the standard way of the development of the immune response and is not something that would catastrophically challenge the organ during the surgery. Hyperacute graft rejection, as I said, is something you do not want to see because it's going to happen within minutes to hours of the engrafted organ being put into place. And it's caused by preformed antibodies causing a reaction, complement activation, destruction of endothelial cells, inflammation, and thrombosis. And so it will immediately cause the failure of the organ and its failure to perfuse normally. And what this typically reflects is the fact that the surgical team failed to match ABO blood groups and do what we call cross-matching between donor and recipient, which are the absolute essentials that I will go through and I want you never to forget. Because remember, if I fail to identify those preformed antibodies in my recipient, there's really no point in wasting time to do the surgery because it is destined absolutely to fail. The special case of graft versus host disease is basically the reverse of what we were speaking about a moment ago. In most grafts, what we're doing is we're taking an organ, giving it to a recipient, and then the recipient is the individual who looks at the graft and says, I don't like you, you don't look like me. But in the special case where the tissue being transplanted is bone marrow, or to a lesser extent, liver, because there are immunocompetent cells in the liver, what happens is that the cells that are immunocompetent from the engrafted tissue will react against the recipient who has received them. So it's the reverse of the recognition. Instead of recipient against graft, it's graft versus host. Well, realize that in most of these cases, the amount of tissue that is being transplanted is significantly less than the mass of the patient who is receiving that engrafted tissue. If I'm engrafting a portion of a new liver, that is a much smaller amount of tissue than the entire human being who is receiving it. So what has to happen immunologically for such a rejection to become life-threatening is that the engrafted cells have to proliferate. They have to clone themselves in order to reach a density of concentration that there are enough of them to actually cause the damage to the host. So where I see these problems first is in rapidly dividing tissues of the body where the grafted tissue is reacting against the host tissues there. And because of the natural high turnover in those areas, the body is now being stressed to turn them over even more rapidly. Now, as you might imagine, graft versus host disease is really a reflection of the function of the Roux-Busch rule of twos. And if you remember how that worked, remember, when I have stimulation of immune cells with a signal involving MHC class 2, the net result is that I make interleukin 2, or as we said, 4, and those are my cloning cytokines that result in the cells eventually dividing in two. So in the cases where I have graft versus host disease, it's normally primarily an MHC class 2 mismatch because that generates the interleukin 2 or 4 that I need to clone the cells from the inoculum, and that's what's necessary in order for those cells to reach a density that they can actually threaten the life of the recipient. Now, when I tissue match my donor and recipient, realize in cases where a patient is critically ill and I simply do not have time to do these processes, then the only requirements for transplantation today will be ABO blood grouping and cross-matching. Okay, both of those are designed to detect pre-existing antibodies. I'll go through the ABO blood test in a second, but even now, let me simply say that cross-matching involves taking the cells of the donor and putting them into culture with serum from the recipient. If there are any antibodies of any kind in that serum that bind to the cells of the donor and cause a reaction, then I cannot use that pairing for the donor and recipient pair. Okay? These sorts of antibodies tend to be rather common in multiparous women because with each pregnancy, one tends to make a response against these alloantigens, and so they still may exist in the blood at the point that a transplant is necessitated. The ABO blood matching, of course, is done by mixing erythrocytes with known sera. And what we see as a result of that is if there are antibodies in the serum that recognize the red blood cell type on the cells, then I would get a glutination of those red cells, indicating that I have a reaction between the antibodies recognizing the erythrocytes. Okay? The reason why it's important to do this, of course, is that these ABO antigens are also found on endothelia. And so if I do not protect against antibodies that could bind to endothelial cells and destroy the vascularity of the graft, then I am predisposing things to failure. Now, when you think about how this happens, realize that persons who have blood type O do not have either A or B antigens on their membranes. So therefore, since they have not seen those two antigens, they will possess anti-A and anti-B antibodies in their bloodstream. They will make those in response to the glycolipids from their normal flora. We say that these persons are the universal donor for blood transfusions because their blood cells will not be recognized by anybody of another blood type. Persons with A blood have A antigens on the surface of their red cells, so they have only anti-B antibodies. They're protected from making antibodies against A because those would bind with and agglutinate their own red cells, which would be disastrous. Persons with B blood have B antigens on the surface of their blood cells and make anti-A antibodies for the same rationale. And persons who have AB blood have both types of molecules. Remember, they are codominantly expressed. And so they would make no isohemagglutinin antibodies. Therefore, they are described as the universal recipients for blood transfusions. It's safe to give them any type of blood because they don't have any isohemagglutinins against any of them. Now, needless to say, you match this as best you can, because if you don't, you are predisposing yourself to catastrophe even during the surgery. If I have enough time to do the remaining tests, it's usually in cases where my patient can expect a living donation. So in cases of bone marrow transplantation, in partial liver, partial lung, kidney, those sorts of transplants, I can anticipate a living donation. In the case of a heart-lung block, of course, I have no time. So in that case, I would simply match and cross-match. But if I have time, realize that we have found empirically over the decades that we've been doing transplantation that the most important alleles to match are A and B and DR. A and B are class 1 alleles. DR, of course, is a class 2. And I will say to you, if you are ever in a situation where you have to choose because you cannot match all three, then it is better to match DR, the class 2 molecule, because remember again, the Rubush rule of 2 says that if I can keep proliferation from happening by virtue of stopping interleukin-2 synthesis, by virtue of stopping recognition at the class 2 level, I end up having a much better chance for success. Okay? That may seem counterintuitive, but make certain you realize it's because of the way the Nirvana diagram is set up that it's really best to talk to the general. If the general is not aware of a problem, he's not going to be sending the cytotoxic soldiers out to do death to the graft. Now, let's start with MHC class 2 testing, okay? MHC class 2 stimulation leads to the production of interleukin-2, which causes cells to divide into 2. So in this assay, I'm going to measure cell proliferation. I'm going to take the cells from the donor and I'm going to irradiate them so that they cannot proliferate. Okay? I'm asking the question if the recipient cells recognize the donated cells as foreign. So I want the donated cells not to be dividing. I'm asking if the recipient is going to destroy the donation. Okay? The cells from the recipient are now added in culture, and I provide them with a source of radio-labeled nucleotide precursor. So that if the cells from the recipient look at the cells from the donor and say, that MHC looks foreign to me, then what will happen is that interleukin-2 will be produced, and the result will be that I will begin to synthesize new DNA, which will cause the increase in radioactivity of the culture. So if the culture rises in its radioactive count, that's a bad sign, okay? The best result would be no increase in radioactivity over the background level, because that means that the recipient cells looked at the donor cells and said, hey, I don't see anything funny here. I'm fine with you. Okay? Class 1 testing is done either by flow cytometry, which is something that we'll go through in our final chapter, or by a microcytotoxicity test, which I'll speak about here. What I have to have if I am a laboratory that supports a transplant team is a very large stockpile of specific antisera that recognize all of the possible alleles in the human genome as far as HLA is concerned. And realize, as I said before, this is the most polymorphic genetic system in the human body. So there are literally thousands of variants of these. Now, you can do some focusing and saving of time by understanding the common haplotypes in particular ethnic groups or particular regions, but you still have to do a tremendous amount of mixing and matching to see what happens, because it's really hit or miss. I'm going to sequentially treat the cells of the donor and the recipient with antisera against all of the alleles that I have. I'm then, after that has had a chance to bind and I've washed them, I will then add complement to each of the cultures. And if the antibody bound to the cell, reflecting that it saw its appropriate epitope, then what would happen is that complement would be activated and the cell on which the antibody bound would have a leaky membrane result. So when I add now a colored dye, that's taken up by the cells whose membranes have been induced to leak. And so I identify the color change in the cells as the ones that responded to the particular antisera. So I have to identify 2 A's and 2 B's on the cells of both donors and recipients, which is quite time-consuming and is the reason why we don't have the luxury of time when we're dealing with an acutely ill patient. Anti-rejection drug strategies are very similar to those that we mentioned with hypersensitivities. We have to basically immunosuppress the patient for life. Even in the case of lifelong immunosuppression, we eventually will have damage to the tissue, but we can keep it to a minimum. And we typically use 4 categories of maintenance drugs. The calcineurin inhibitors, cyclosporine and tacrolimus, the anti-proliferative drugs, mycophenolate mofetil and azathioprine, mTOR inhibitor, sirolimus, and steroids like prednisone are all used in these capacities. Notice that we also have basilizumab and daclizumab, which are inhibitors of the alpha chain of CD25, which is the high affinity interleukin-2 receptor on T cells. So those are administered during the acute phase to stop the recognition by T cells and their cloning. Before you leave, simply look at this list, make certain you can explain the answers to each of these individual topics. As always, I'm not going to read these to you, and I did not include any #MMR comments because I think it's fairly obvious what the importance of transplantation is in medicine today, and the reasons why you need to understand the rejection techniques and how we avoid them.